Littleton Board of Health meeting. We have a 7 o'clock public hearing on 5 Fir Lane, Craig Lafferty. Discussion and potential vote to allow the homeowner to finish rooms in his basement at 5 Fir with the use of a deed restriction. Hi, Mr. Lafferty, how are you?
Hi, good evening, how are you?
Doing well.
Can you hear us okay? Is our mic working?
Yes.
Excellent. Is the best place to start showing a floor plan or letting you guys ask any questions? Whatever you guys need us to do, we're here for whatever you need.
Sure. I think everyone here has seen the floor plan. It's in our packet.
Okay.
It's pretty clear. Does anyone from the board have any questions right off the bat? Craig, why don't you go ahead and just give us a little description of what you want to do?
Yeah, sure. What we're just trying to do is finish the basement to basically have a large open space, largely for our 3 kids to hang out with their friends and not be as noisy when they're upstairs. But then as you can see on the one side of the plan, I'd like to have a home office down there, for my work, to have a door there so I can shut the door if the kids are down there to try to keep the noise level appropriate when I'm on call. So I recently switched jobs about 6 months ago, so I'm largely almost 100% remote when I'm not out visiting customers. So that's one of the impetuses for the room there. And I think the other thing I want to let you know, I found out we do have a 1,500 gallon capacity septic tank. So I know that was an agenda item that was on the sheet. And then I also think when we look at room counts, even though it does look like we have 9 rooms total, we do have a couple of rooms that are connected, that there's not a wall there. So like from the kitchen to the family room, that's an open space, and living room to dining room is an open space. So I was trying to make the case earlier that we think we have more like 7 total rooms. But ultimately, we're looking to do 1 open space in the basement, and then the closed office. It will be 2 additional rooms to the plan.
Okay. Yeah, the way I'm reading the plan, I see 9 rooms upstairs on the 1st and 2nd floor. We can discuss whether, I don't think it's ever been considered that the, dining room, living room, whatever count as 1 room, even though it's sort of open to each other, given those little side walls. But
yeah,
I'll go ahead and just read our health agent's notes quickly, and then we can open up to the board for discussion.
Great.
This is from Jim Gariffi. Proposal to add living space to an existing house triggers a review of the existing sewage disposal system to ensure the system has the capacity to accommodate the proposed addition. As a part of this process, we also review the floor plans for the existing house and apply the definition in Title V to arrive at a total bedroom count. The capacity of a sewage disposal system for a single-family house is determined by the number of bedrooms in the house. The septic system for this house is designed for 4 bedrooms, 9 room total according to Title V of the State Environmental Code. For houses which have more than 8 rooms, the number of bedrooms is calculated by adding all the rooms, then divide by 2 and round down. The floor plans on file with the building department reveal the house has 9 rooms, including 4 bedrooms. The assessor's record also lists the house as having 9 rooms, including 4 bedrooms. The proposed finished basement would add 2 to 3 rooms to the 9 existing rooms, which would exceed the design capacity of the septic system. The board has been comfortable with allowing me to sign off on plans which add just 1 additional room. This proposal may add 1 to 2 more, depending how you view the layout of the basement plan. As a condition of the approval, the bedroom restriction must be recorded on the deed. I have no doubt the existing homeowner plans to use the space as proposed, but the board needs to ensure future owners understand the use of the septic system beyond its approved capacity may cause the system to fail prematurely. So what he's saying here is that there's 9 rooms. It's on public record. It's what the building plan stated with the building department. And you are asking us to basically add 2 more rooms in addition to that, because there's no wall between your proposed new family room and the, I guess that would be a playroom / gym area.
Yeah, I think that's, the only real enclosed, so it's a little hard to read that handwriting of our contractor there, but the unfinished storage area, that's not going to change where the bathroom is. That's just going to be open space basically there. Bathroom, obviously, the open space where it says family room, no walls there. The only wall that we're really looking is that home office on the lower left-hand corner, where that desk area would be. So that would be like the one enclosed room, and then everything else basically is the family room, correct? Like a game room or open space for the kids, or my son to put his weight bench or whatever.
Mhm.
Yep.
Yeah, so the board has a history of allowing 2 rooms over the count, which would allow 10 rooms with a deed restriction. And I don't know that this board has ever done anything different from that in its history. But we can open up the floor to any questions or comments from board members and see what we can do here.
I think you meant 1 room, right? Not 2 rooms.
1 room over the count, and then 2 rooms with a deed restriction. So we would allow this to go to a 10-room total with a deed restriction.
I'm a bit confused here. Your description, does the configuration propose add 2 rooms as you see it, or does it add 1 room as you see it?
As I see it, this adds 2 rooms.
Okay.
With deed restriction.
Well, the idea is I can see 1. I'm thinking of the capacity of their system and the fact that they do have the bathroom facilities and everything else, to, as it were, use it. So I understand the desire here, and I'm not worried about how you're going to use the rooms. I'm sure you're going to use them exactly as described. It's a question of, are we creating a problem even if it's under a deed restriction? Because if we add more than 1 room here, we're really pressing against the capacity of the system. I'm just putting the two of the capacity of the septic system and the number of rooms.
Right. So typically we'd allow 10 rooms total on a 4-bedroom septic with a deed restriction. So yeah, Craig, would it be possible to eliminate this wall here? So just make it 1 room in the basement?
So I think if we look at that, you're talking about on the floor plan where the office is, to have that 1 wall by where the gym area is. Is that what you're asking?
I think so. Yeah.
Yeah. I mean,
Wait, I don't think we're on the same page. Can you go back to the floor plan?
Sure. I could share my screen.
So what wall is he asking?
I think so. If you see where it says home office, and then I'm colorblind. Was that a blue line?
Yeah.
Okay. And then above it where it says gym. So you see that you're asking for that not to be a wall right there. Is that correct?
I believe that would be a good solution. Yeah.
So that this whole thing would be like an open area without,
But I guess I'm curious because it's not a guest room. It's not like we're adding additional people to use the septic system. I understand what the law says, but if it's not being used as a guest room, it doesn't mean that there's going to be additional people using our septic system. It just might change where the person uses the septic system in our house.
Yeah, mainly it's to protect the future owners who may
Buy it later.
may see that as another bedroom.
Okay.
It's as Kevin mentioned, it's not anything against the people bringing the plan forward. We know you're going to use it this way, but somebody else buying the house in the future will look at this basement and go, there's basically a full bathroom and a bedroom looking area. And that's what we have to concern ourselves with.
No, I understand. So you're saying that if we eliminated the plan, that wall wasn't there, we would be okay to do this basically 10 room total in this house now with this deed restriction? Correct.
Okay.
Can I just ask a question here? I'm sorry. You have it. There's an unfinished area, unfinished storage I'm looking at.
Yep.
Is I want to make sure I understand on my sketch in front of me, it has, it looks like it has some walls that basically, there's a bathroom which I'm assuming has 4 walls, or at least right? Okay.
Yeah.
Okay. And then inside the unfinished storage area, what kind of, I realize it's unfinished, so this is all, that's an existing wall. There's like a black line that comes out around what looks to me like a,
Yeah, so that's not an existing wall. What the contractor was going to try to do, so the HVAC system is that 1, 2, 3, that 4 dot
oh yeah,
rectangle. That's all HVAC. So he wants to put some kind of, I don't know, Chris, do you see like a barrier or something there to
Something around it.
something around it to protect that? But that's just like an HVAC noted area, and this in between the HVAC and the bathroom, he wants to put a door there, so there could be a door to walk into the unfinished storage to get stuff out of that area. But that's what that is, that black line.
Yes.
What that black line's representing.
okay. But that's unfinished. Is that correct? I mean,
Correct.
Yeah, not
That is-
gonna do anything.
it's uninsulated. Is that the idea?
Correct.
Yeah.
And the home office area, that's insulated.
That would be insulated with ventilation into that area. That's correct.
Okay, so it's not insulated with ventilation at the moment.
No,
No.
right now it's like the
Unfinished.
coldest room in Littleton, Mass is our basement. If you want to check it out. No, there's,
Oh, if we uninsulated it, would that make you more likely to let it be considered a room?
Of course not. That's not where I'm heading, and I know you know that. That's a lot. No, I'm trying to.
kind of kidding.
No, that's no. I do know what it's like to have kids and have an office and all the rest. So I'm trying to figure out if there's a way for you to execute your plan without having a lot of. Has your whoever's helping you with this, has it been suggested at all? I mean, I don't know how feasible it is. It's great. I'm just looking at the diagram to have your office where the unfinished storage area is, because you already have. That will relieve the problem because there wouldn't be any other. That's one wall. Is that right, Kevin?
If it's not heated and not insulated.
Right.
Yep.
So if he didn't do the home office the way it is, this is already has. Does that solve his problem?
Is the basement finished at all right now, or is it completely unfinished?
yeah, right now the entire basement is completely unfinished without any walls or anything at all. It's just a whole pretty big open space.
So finishing the basement without putting up anything other than insulation and lights, that creates a room. Adding the office creates a second room. The unfinished storage and HVAC area is not considered a room. It's not habitable. It's storage and facility. Bathroom does not count. So finishing the basement, that creates a room. Adding the office into the basement as well with walls and a door creates a second room. So, and I think I don't see a way around that at that point. That puts us at 11 rooms. Finishing the basement puts you at 10.
Yeah.
Adding the finished basement makes you 11.
Yep.
No, that we get that. That makes sense, and I wouldn't want to have to be back in that unfinished space. It would be kind of. I probably would only be able to be down there maybe in the summer just a bit, but.
I wasn't thinking of leaving you unfinished. That's just, I was trying to.
Yeah.
Do something else.
Yeah,
All
and that's a good storage area for us too. It's just kind of a catch-all space, but.
So I see this being able to be done if it's just one room in the basement finished.
Okay.
All right. Is there a motion or any comment on that?
I was just going to say, I think what Mike was trying to get at is that if the entire top of that was finished and the HVAC system and bathroom became a barrier that's not a wall, then that's one room. If you wanted to consider leaving the office as unfinished storage area, you'd end up with a T shape of one room, right?
Yep.
Are you suggesting we could do some kind of like sliding door kind of situation for that unfinished area?
Well, the unfinished area can be walled off with a door, correct? For storage?
Yes.
Oh, I thought you were suggesting we not do an actual wall there. so that we could have the wall for the home office.
Turn the home office into unfinished storage, and then finish the area past your HVAC equipment. I think that was the kind of idea.
I think maybe Dan's point comes up almost immediately. We inadvertently created 2 rooms.
Yeah.
Arg.
So
well, I guess what I was asking is, could we make the separation where the HVAC and the unfinished area, could that not actually be a wall so that we could get our walls for the home office? Is there a way we could skin the cat that way?
No, that's.
I just don't see it. I mean, if you have a wall, that's a wall. So
Yeah.
Have you? I mean, I'm not trying to tell you how to live, but have you considered putting your home office somewhere else in the house?
Just from a noise component, I kind of wanted to be as far away from my lovely children during the day as possible. So that was the spirit.
But if you have a gym down there and the way you have it, I mean, this is your lifestyle. I'm not trying to tell you to change anything. I'm just trying to inspire you so that you can get, I mean, if you're trying to get your kids a reasonable distance away from you, it would seem to me that, that might be a way to do it. And they quote, what you have labeled here is the gym. And as long as there are no walls or anything, you could finish it to the point where it's a functional gym and just don't put up doors. They come down the steps and they are in a gym.
Yeah, I think we can kind of try to solve for that, and make the best use of that space. Or I just get down there when hopefully they're in school most of the time and it'll be quiet down there anyway. And maybe that wall won't be as necessary. So that's fine.
I'm sorry, I didn't mean to probe on your lifestyle.
No worries. No, we appreciate you help trying to problem solve.
Is there a motion?
What form would you suggest, Mr. Chairman, that the motion should take?
That the board will allow the basement to be finished so the residence has no more than 10 total rooms.
Okay. So, but basically just allows it to be finished without the installation of doors.
10 total rooms in the house.
Okay.
I second. It's going to be a deed restriction?
Yep, the deed restriction. So Mike, did you move my comment there? So
yes,
it's actually a motion?
yeah, I'm moving your comment and
okay. And Gino second.
Yes.
Okay. So roll call vote. Gino Fratelloni.
Yes.
Dan Kane.
Dan Kane, yes.
Matt Wason.
Matt Wason, yes.
And Mike Zeldin.
Mike Zeldin, yes.
And Kevin Baker votes yes. Thank you, guys.
All right, thank you very much. Just from a next step perspective, do I just I'll look online and where the approvals come to say that we're ready to roll with the contractor, just our next steps online?
Yeah, you might need to just resubmit a new fresh copy of plans and then just bring that over to Janet or submit it online, however you're doing it. And Jim will sign off on it.
Great.
And I'll send you, if Jim hasn't already, I'll send you the application for the deed restriction.
Excellent. Okay. Thank you for your time.
Thank you.
Thank you.
We're running a little late, but we have 7:05. Can we just take care of the minutes from December 15th? Did everybody have a chance to read them? Is there a motion?
I'll make a motion to approve the minutes of December 15th, 2021 as written.
Okay, Gino second. Gino Fratelloni.
Yes.
Dan Kane.
Yes.
Matt Wason.
Matt Wason, yes.
Mike Zeldin.
Mike Zeldin, yes.
And Kevin Baker votes yes. So 7:10, we have a COVID-19 update. I don't believe Jim's here today. Is that right, Janet? Okay.
That's right.
Correct. He's in his Boxborough meeting tonight.
Okay.
So
we do have Katrina.
We do have Katrina. Let me just move her on in.
Thanks. Sorry we're late.
I'll try to speed through.
Don't worry about it.
All right, hold on. Trying to figure out where I should be here. Assuming you see my slides. All right, let's just dive in. So the last time I presented here was that first week of December, right after Thanksgiving, and Omicron had just been identified, and we had no information about it basically. And since that time, Omicron now is not only here, but it represents nearly all genomic sequences in the US and actually in New England at this point. So Omicron really has shaken up what we know about COVID and how we respond to COVID and some of our things that we do and have used successfully over the last 2 years. Some things we have to kind of keep multiple things in our minds at the same time throughout tonight's presentation. So first, Omicron is seemingly less severe for most individuals compared to the prior variants. Symptoms appear earlier in infection than they did for the prior variants, often before an individual is infectious. So that's actually a great sign that someone is infected. But Omicron is significantly more transmissible than Delta, and it's causing significant spread and strain to our healthcare systems, schools, other essential systems, because so many people are sick at the exact same time. So if we're looking at the state data, keeping those things in mind, we can see that just with the trends, everything's kind of not only trending up, but up rapidly. And I want to spend a little time going into each of these individually because things have changed a little bit. So the first thing is the number of tests and test positivity. So these graphs here are the number of tests conducted in our state, and not only molecular, which is on the left, but also the antigen tests on the right that we have records for. So we actually currently have the highest levels of testing that we've had through this whole pandemic, which is great. Our state has really continued to try to do enough testing to capture as much data as possible. And that's a great sign. And in particular, the number of antigen tests conducted and reported to the state has actually increased significantly since mid-November when they started to become more available on the market. So we're still doing a lot of testing, which is a great thing. The test positivity in our state are now around 22% though, and that's significantly the highest it's been through this whole pandemic to date. And it's seemingly a straight line up. And I know that's concerning to a lot of people, but I also know this is one of the most least understood metrics. We keep using it wrong. So I just want to remind everyone that test positivity is the total number of tests conducted, positive tests, divided by the total number of tests conducted. And so to be clear, this does not represent a proportion of people. It's the number of tests that were positive. And so test positivity really gives us this indicator if there's enough testing going on. And if that testing and reporting, both of those combined are going on, that helps us ensure that the case counts and the rates are actually reliable. So in general, we've been looking at test positivity above 10%, indicating that we aren't doing enough testing or reporting of cases being captured in the data. So we know this is an underreport, everything we show from here on. And there are multiple reasons for this. We are still recovering from some of those holiday lags. Test reporting's taking longer to come in. So instead of 24 hours, we're 48, 72 hours before people are getting PCR test results. And that's getting into the data. So people are using more at-home rapid tests, which is a great tool for individuals to use, and highly encourage people using them. But depending on who you are, that may not be getting into the data. And then it's just more COVID around. So more people are being exposed than are being captured using tests. Exposed in cases. So when we look at cases, this is restricted to the last 6 weeks. Mass is currently averaging 20,000 case reports a day, which is significantly higher than at any other point in the pandemic. You can see that there's the case lag is actually, this is that test reporting lag. These last few days, it used to be 2 days. Last 2 days weren't so reliable. And now we've kind of getting into 4 days that aren't complete. So again, that reporting lag is important here to keep in mind. Last January, so we have 20,000 a day now. Last January at our peak, we had 6,000 cases a day. So significantly higher than at any other point that we've had. So, and you can actually see when you look at this, this is right here. This is the week of Christmas, and right after Christmas, we've just shot right up. So I just told you on the prior slide that the test positivity indicates that we're not capturing all the cases. And that's not something that's new. This is we know cases have been underreported this entire pandemic. It's an undercount. And I've already heard from multiple people in town that because we're not capturing all cases, that this data is crap and should be just disregarded completely. And I would respectfully disagree with that point of view. I know this data is an undercount, but nonetheless, the number of cases that we measure continues to trend higher and compared to other points in the pandemic as well. So we can use these to see trends to get a feel for which direction we're moving. And in some sectors, reporting is better than other sectors, and we can go through that. One of those sectors is age-based. So for example, the case data is much more reliable for age groups where there's reporting requirements for cases. An example of this is K-12 schools, colleges, long-term care facilities. They're all required to report to the state. And that means that data for those age groups is much more reliable. So those age trends are a little more accurate. Case numbers for groups that don't have these reporting requirements are maybe less reliable, but again, we can use this data to get a feel for trends for each age group. And we know we're missing cases. So we just have to take that in mind, that we're not capturing everything. That's not the whole picture. And as you can see from the age breakdown from this data ends January 1st. We'll get an update tomorrow. That the 20 to 29-year-olds and 30 to 39-year-olds have the highest rates right now. And that school-age children, these blue lines, they're actually plateauing right around the time they were getting their second doses of vaccines. And that's when Delta was still here. And then at Christmas, we started heading up again. So again, not the, don't completely disregard it, but do recognize its limitations. And this is hospitalization data from the DPH. At this point, the 7-day average is 3,000 people in the hospital each day. And about 55% of those are not fully vaccinated, which makes our vaccines seem horrible, but that 45% are a mixture of people who are either 2 doses or 3 doses. Most of those in the hospital, it sounds like they're 2 doses instead of the not boosted individuals. This is definitely higher than last winter's peak at this point, but it's lower than spring 2020. And keep in mind that we know cases are at an all-time high. So the proportion of people in the hospital at this time is lower than it has been before. So, but when you think of hospitalizations, when we overwhelm our hospitals with number of people and they exceed the beds, then our care capacity is greatly challenged. It's in critical settings. So at this point in time, elective surgeries have been suspended. The National Guard has been deployed to assist many hospitals. You hear some stories from doctors. It's a little scary, actually. This is Icu and Intubations, and they're actually at similar levels as they were last January. Again, vaccination status, health history, and age seem to be the largest predictors of who ends up hospitalized and needing high-level care, such as ICU and intubations. Again, it's reported that most people needing this high-level care are unvaccinated or may not have had, who are older and have not had their booster. And the state is in the process of redefining and collecting data with altering the COVID-19 hospitalization definition to try to get a feel for those who are in the hospital for and with COVID-19 and the distinction between those. And it is not clear to me, I can't find the definition that they are using right now. So we have to wait for the data to come out and then to see the definitions to actually interpret that data. But that should be coming by your next meeting.
Aren't they changing that to call out who did not have COVID when they were admitted to the hospital and then got COVID while they were in the hospital?
I'm not sure, Kevin. I don't want to jump the gun on that. I want to see how they're defining it, because I think that's really important for the nuances that we'll learn from it. So until I see it, I'm having a hard time. Each state's doing something different. This isn't a federally defined variable, so I'm not sure. And I don't want to speak out of line now before I see it, if that's okay.
Oh, Dan may know.
But I don't know. So currently, the data that they're reporting is patients who arrive and end up with a positive test on arrival or at time of admission. If you become positive, if you were negative on arrival, became positive while you're hospitalized, that is not in the current numbers.
That is true.
Kevin's question of, did I get it in the hospital? Is that in the mix? No. If I'm in the hospital for whatever reason, and I'm positive on arrival, I'm in the COVID.
Okay.
New criteria is not out yet. It is publicly available of what the new criteria is going to look like.
Yeah. I know they started collecting data this week, but I just don't know how or what is being collected or how it will be presented. So we'll see.
Okay.
This is the hospitalization bed capacity, bed occupancy, I should say. And this slide, I have to say, is concerning. Bed capacity is quite high. No matter why you are hospitalized, if there is not a bed for you, then you're not going to get the care you need, regardless of what that reason is that you were hospitalized for. So today, there were, or as of yesterday, my apologies, 1/11, 94% of medical surgical beds were occupied and 87% of ICU beds are occupied. Although I have heard over the last week, some of those have come to zero at some points in time over the last few days. So they kind of come up and they come down. A bed might free up, but they're quickly filled. And there are some regions in Massachusetts, including our own, where there is little to no capacity left in our hospitals. So it's also important to keep in mind that hospitalizations are a lagging indicator. They typically begin to decline 2 to 3 weeks after cases start to come back down. So even if cases started to decline today, we would not see any improvement on our hospital situation until the end of January, maybe even into February. So this kind of staffing issue, fewer staff, no replacement, staff getting sick themselves and having to be in isolation, that is also being seen across all sectors, impacting nearly everything, local businesses and town departments included. So this is why it's really important for us to do what we can to prevent spread as much as we can, so that we don't continue to put added pressure onto these essential systems that we rely on. And then this is deaths. Here, it's the confirmed COVID-19 deaths in Mass. Deaths are currently averaging 42 per day, which has trended higher since Thanksgiving. But this isn't the highest it's been, which is good. Like every peak, we seem to come down a little bit more. So this is given the number of cases and even the number hospitalized, this is a nice improvement over the past. And per a recent CDC publication, death among people who are fully vaccinated is very rare. It's 0.003%. So very low. Okay, so getting a little more local, we're going to do Littleton. Last week, we had 166, for the 2-week period ending January 1st, that is last week's DPH report, there was 166 cases in Littleton reported. This next 2-week period, which will end January 8th, we have 293 cases expected to be reported tomorrow. So that's a significant increase and rapid increase. So we had a doubling between the weeks between Christmas and New Year's and another 75% increase above that. So Littleton has a lot of cases in it and the highest by far that we've ever had. And then this data is from the January 6th DPH report. This will be updated tomorrow. Littleton's average daily incidence rate per 100,000 was 121.5 per 100,000. That's based on the 166 cases. And then the other areas we track continue to also trend higher and also a doubling effect as of last week's report. So, but we know based on our test positivity, I think we had on 14% here in Littleton. We had a similar number of tests that we've had for a long time, 14% test positivity. We know this is an undercount, the 166 that factored into this graph. So we know, and all of the areas that we track also had an undercount, a high test positivity. So we know these are not representing all the spread that is in our communities. or our state. So this is the Littleton school data. It is based on the health notification letters and the dashboard that LPS creates. You can see the 19 was the week leading up to Christmas. This is the whole district combined. 19 is the week leading up to Christmas break or December break. The 48 is what was reported to the schools over December break. And the 83 is that first week of January, ending the 7th, I believe. So we had this doubling and then a near doubling event happening over the holidays. And then this week so far, there's been 70 cases. That's updated as of today. So there's 2 more reporting days into this week. So we'll see what happens. But the schools have been, the nurses have been working their butts off doing pool testing, rapid testing, test to stay, all the contact tracing they can do, things like that. So I'm going to applaud them because they've been doing this great work. So we're hoping that this week doesn't far exceed last week, and that we see one of the important things about getting school back in session was to get people access to these tests so that we can start breaking some chains of transmission, and hopefully that's happening in the school. All right, so this is the vaccine coverage for Littleton, as reported by the DPH last Thursday. The proportion of fully vaccinated residents continues to increase. We're now at 85% of all residents, with another 10% who are partially vaccinated, and 5% have not yet started vaccination. A portion of those are 0 to 4 aged residents. So 5 to 11-year-olds became eligible just for their primary series at the beginning of November. We've talked about this. And at this point, 68% of those are now fully vaccinated. That was a big increase by the end of December. And another 18% are partially vaccinated. And this town did one of their 4th clinics for that age group on Monday, and also had some boosters and going on for our town members. So I know there's a number of 5 to 11-year-olds who will be joining the fully vaccinated category very soon in our town, which is great. And then the state finally released some data on boosters, which is very helpful. So approximately, you become eligible for your booster 5 months after your last Pfizer or Moderna shot, or 2 months after your J&J shot. Here I'm estimating that if you're fully vaxxed and it's been 5 or more months, then I'm saying you're eligible. We don't know the breakdown of who got which ones, but I think most people got Pfizer or Moderna in our town. So this is why I chose this definition. And using that definition, approximately 85% of Littleton's fully vaccinated population are now eligible for boosters. And of the 7,000 who are eligible, about 61% have already been boosted. And there are about 2,700 residents who are eligible, but not yet boosted. 12 to 17-year-olds became eligible recently. So that group is just most recent to join that number. So boosters are that important, or really important against Omicron. They help to restore some protection against symptomatic breakthrough infections and also hospitalizations and deaths. People who are boosted are much less likely to need to be hospitalized too. It's not too late to get boosted. Like once you get boosted, your immunity starts to build within days, and up like a week is really what people are saying. So after receipt of your booster. And so I know that Jim is running, Neshoba Associated Board of Health running boosters in Shirley on Wednesdays. I think Moderna is what they are offering for boosters. So the Neshoba Associated Board of Health is a good resource for boosters if you're looking for them. But keep in mind, kids age 12 to 17 can only receive a Pfizer booster. So you have to look specifically for them. So I just ran through the booster information a little ahead of time. I made this graphic, showed it a couple weeks ago, updating who can get what vaccines or boosters. So again, if you're 18 or older and you can get your booster, you can get any of them. If you're 12 to 17, you can get your booster now. It has to be a Pfizer if it's been 5 months since your second dose. And then children age 5 to 11 are eligible for their initial series. And this is the primary best way we can protect ourselves as individuals from severe disease, and actually reduce spread and reduce infection. So this is our best tool. The other thing that's changed recently is the CDC's guidance for what to do if you've been exposed to someone with COVID-19, which is the quarantine. They've changed it based on your vaccination status. So if you are 18 and older and received all the recommended vaccine doses, which includes boosters, then you can basically wear a mask for the next 10 days. And if you are 5 to 17 and you've got your 2 primary dose series, then you can just wear your mask for the next 10 days, or if you've been a confirmed positive in the last 90 days. Otherwise, if you are not fully vaccinated by the new boosted standard, which is so important against Omicron, then you are advised to stay home for 5 days, to isolate at home, quarantine at home for 5 days, and then wear your mask for the next 5 days. If you're able to, we recognize that there is not always possible for everyone to stay home because of staffing shortages and things like that. So if you can't, you have to wear your mask for 10 days, and everyone is recommended to test on day 5, just to see if they are a case. And then the CDC also changed the isolation guidelines. So if you test positive for COVID-19, regardless of your vaccination status, everyone who tests positive needs to isolate for a minimum of 5 days. Keep in mind that 5 days may not be long enough with Omicron. Remember at the very beginning of my presentation, I said that people are experiencing symptoms earlier in infection and actually may not be infectious right away when they start having symptoms. And so if you're counting 5 days from your first symptom, you may still be infectious at the end of your 5-day isolation. So it's estimated like 30 to 40% of people will be infectious on day 5, which means many will return to work and school still infectious. We have to be very careful about this. So if you have no symptoms or resolving symptoms, which include resolution of fever without fever lowering medication for 24 hours, then you can leave isolation per the CDC guidance. And the state has adopted this. But you need to wear your mask for the next 5 days. And because you might be infectious, this mask is really critical now to wear it every time you're around someone else. And then it would be really advisable to stay out of non-essential settings where you can't wear your mask all the time, such as a restaurant, a gym, a social gathering, things like that. Like just keep yourself to the essentials during this next 5-day period. If your symptoms worsen at any point during isolation, you should be talking to your doctor. And then while it's not required, if possible, because people can still be infectious after day 5, it's really advisable to take an at-home rapid antigen test, not a PCR test, the at-home rapid antigen test to see if you're still infectious, if you can, before you leave isolation. They're a really useful tool. And on day 5, if that rapid test, you are contagious to others and you could spread the virus. So if positive, you should continue to isolate until day 10 or until another test tells you you're negative. And I have to say that the number of people I have seen try to do a test to exit isolation and still be positive on day 5, day 6, day 7, all the way up to day 12, there's a lot of people who are still infectious and that later into that period. So just part of that's because their symptoms came really early, even before they lit up a rapid test. So Omicron's shifted our time frame from what we used to know, but that means we have to be really careful when we exit isolation at this point in time. And if you are able to, then you could enable your Mass Notify on your smartphone. That just helps shares those Bluetooth keys with people to privately tell you if you've had an exposure, and then if you test positive, whether a PCR or a lab, like a test that you get in a clinic, or if you test positive at home, you can then enter that information, and then the people you were around in the last 14 days would get a message saying that they have been exposed. So that is it for today.
Thank you very much. Board member comments?
I think you're doing a good job. I hope we don't have people getting sick. It'd be nice to hear that.
Yeah. I have to say, with Omicron, Gino, most people in at least my age group and our kids' age groups are having a pretty, like they're having fevers, they're not feeling well at all. They definitely are sick, but they're able to handle it at home, which is wonderful. I think the older you are, the worse your health is, then that's where the risk really, I don't know how people like that are handling it. So take care of yourself if you do get sick.
The question is, everybody's got a booster, most of the people there I know.
Oh, that's awesome.
Are we going to get a more booster, more this, more that? It's going to be like every month we're going to get something?
That's a really good question. I can't answer. I could see that we might need like a flu shot a year kind of situation before, see if it's seasonal, but we're still learning. So we'll have to keep an eye on that one.
I can see the flu shot. I understand every year is better to get it. I hope you don't get anything else besides that. Be trying to be healthy and wash your hand, cover your mouth, stay 6 feet away from Gino. Only the pretty girl can get closer. I give him 4 feet.
Yes, Mike.
Yeah, I'd just like to point out that although there's nothing magical here, it's already been mentioned numerous times, but I think it's worth mentioning again. And that is that one, masking makes a difference in the extent to which it just reduces your risk of either transmitting or getting the disease. And this particular variant has been selected quite literally because it's so big, because of its features and its ability to not only move more effectively from person to person, but in spite of some of the barriers, including vaccines, put in its way. Yeah. So I consider this to be a virus that's basically, shall we say, putting a drive on to become, I hate to use the term now, endemic. I mean, it's sooner or later, it will have infected enough of the population. So it will require, I hate to mention this, another variant in order for the virus to be sustained. And so the alert has gone out to keep looking for these because there's so many people carrying it, which is also a very fraught situation. The more that people are getting infected, the greater the opportunities are, the chances are producing yet another variant. So what the variant looks like, I don't know. And I'm not saying there's one out there. I'm just simply saying that is the danger here. The second level of danger or one of the levels of danger of having this kind of sharp increase in the number of cases. I'm glad to hear that people are not getting that sick from it or not dying in great numbers, but it increases the opportunities for more variants. The other unknown, which is still to some extent unknown for Delta, is something that keeps accumulating in the background, and that's long COVID. And that continues. Those clinics and those studies are now for the first time appearing. And I just want to say that the incidence of long COVID is great enough that it's going to be a problem when the virus eventually, or the pandemic, turns into an endemic one. We're going to have people who are still carrying the signs and symptoms of disease that may not necessarily be fever, but they'll be impaired in various different ways. And there'll be large numbers of them across the country. And for all I know, locally. The other thing is, and it's very frustrating, and that is that at the moment, the relationship between cases, as I think Katrina's mentioned, and hospitalization has been, quote, decoupled. I think that simply means that we're missing a lot of cases, but the number of people in the hospital is something that's countable. And very frankly, unless there's someone else out there, including on the board, we have no idea, even from 3 weeks ago or 2 weeks ago for sure, how many people in Littleton, much less in our district, have been hospitalized due to COVID. I have no idea. So for all I know, we have yet to receive the full blow of this virus, because maybe we haven't reached the critical mass of people necessary to uncover all those who are likely to end up in the hospital. I just don't know. Our demographic, because of the age, would suggest that the hospitalization rate could be larger than we might realize, or it could very well be that people are masking, paying attention, and are boosted so that the hospitalization rate here actually, for any number of reasons, may be in fact quite lower, let's say, than it is in some other places in Massachusetts and the US. So what I'm saying long term is the only action item left, unless someone here has some ideas, is we have to be far more aggressive. I think as a town, we should be far more aggressive than we have been about making the right kind of masks. I'm talking here N95s available, both through education as well as providing masks for people who may not afford them, may not know how to pick them, may not know how to get their hands on one. And very frankly, if the town doesn't have the bandwidth to do it, they better find it. Because they're at a minimum, I believe it would be very, very useful for people to have access to those, especially if they want to, basically they have to work or be around people who are working, be around their family, whatever the reason is. The use of the proper kind of mask and having access to them is still quite critical, and there's no excuse why more people can't have access to those and use them.
Thank you, Mike. Does anyone else from the board have a comment before we take public comment? All right. Janet, does anyone have their hand raised?
Yes, Matthew Reed.
Hear me?
Yes. Hi, Matthew.
Hello. I'm glad Mike brought that up with saying with the N95 masks, because honestly, at this point in time, a lot of people can't get their hands on them because of the fact that they're either bought out because of the latest conversations on TV, along the internet and everything else. They have literally been selling out like hotcakes again, because there was somebody on the news, I believe it was on CNN or MSNBC or something like that, that pretty much ended up saying that cloth masks are pretty much useless for COVID, and especially Omicron, and the only thing that is useful is N95 masks. So there has been a jump on purchasing on those. And honestly, I'm having a hard time finding them just as it is now. The other thing I wanted to sort of bring up real quick, if possible, is we need to be a little more descriptive, or we need more description about those people who are in the hospital, as well as the reasons why they're in the hospital, because a lot of people who are inside the hospital themselves who have COVID or who die with COVID did not go in there because of COVID. And we need to get that thinned out pretty quickly, because if we're going to start seeing people come up with information saying, well, we have over 100 people inside the hospital with COVID, and we have 50 of them that died they died with COVID, we need to know if they died of COVID or with COVID. And that is one of those things statistically needs to be, because it needs to be taken, it needs more detail, more information, because right now we are running into a situation where all I hear is fear, doom, and gloom. And COVID right now, yes, it's a bad thing. My wife has it. So I'm not just speaking out of one of these things. I probably have it too, because I'm a close contact. And the one thing is that people who are vaccinated, even the triple vaccinate, are getting it. People who are not vaccinated are getting it. People who have two are getting it. It's non-selective. So we need to really nail down these numbers, because if we don't, and we just keep on saying, well, this is happening because we have so many people, like 44% of people inside the hospital unvaccinated. Okay, that's fine. What about the ones who were vaccinated? How vaccinated were they? Because we need to know, because I'm just worried that we're pushing a vaccine that's not going to help. It might limit, it might reduce, but if somebody's in the hospital, I want to find out why they're in the hospital, because if they're in the hospital for a broken leg and they happen to have COVID while getting inside the hospital, that's not the same thing as having being deathly sick and on a ventilator.
Right. Yeah. I don't know if we'll be able to tease out those numbers ever. But we just do the best we can. And, we all know the vaccine, greatly helps reduce the severity of the infection. So
But I
appreciate
think
your comments, Matt. All right. We have a 7:40 public hearing, Board of Health mask mandate, discussion, correspondence, public input and review of the data regarding mask flexibility in Littleton Public Schools. And Dr. Clinchy, I think he's here. He did send an email just stating they're just going to hold off for the time being with the mask flexibility program.
I did just promote him in case you wanted to.
I have a question. I believe that DESI has also indicated that they were extending their system-wide requirement for masking till the end of February.
Yes, that's correct.
So the whole issue of flexibility at this moment still reverts back to a whole bunch of other criteria, and I'm glad to hear that it's not being pursued at this moment.
Right. So for clarification, I just want to make sure that you understand what DESI has done. They did extend the mask mandate until the end of February. They still kept the clause in about 80% vaccination rate. Once you reach that, you have an opportunity to determine whether or not you want to offer max flexibility.
Yep.
And are they taking into consideration the booster?
No, they're not. Not at this time.
So I guess we'll just should we just continue this until there's a better time to talk about it?
Well, it may be an academic question and can be sidelined, but the situation that led to the formulation of the criteria and all the rest, this is not a public hearing. I'm raising the question of whether or not we should close that hearing because it's basically out of date. The data and everything else associated with it has been basically obliterated. The situation on the ground is different. And I'm just wondering whether or not it would be to our town's advantage, the school's advantage, and to a lesser extent our advantage, basically, not necessarily to start from scratch because we have a pretty good idea, but basically to understand very clearly that the rule or the criteria that might be used for flexibility in February or whatever are going to be very, very different.
Yeah, I think we're all under agreement to a certain extent, and we just had a few more I's to dot and T's to cross in regards to the criteria by which masks would go back on.
I was thinking something far more fundamental change, which would be that, this is like measles, mumps, and all the rest of the other diseases, and that we want to have people. Don't want to get into the details, but the situation on the ground could really be changed, especially the change in what the pharmaceuticals that might be available. Who knows what vaccine regimens might be required. It's unpredictable. And I just want to make sure that we have a clear, the details of the past are instructive. They should not be determinative because we probably are going to be looking at a whole new situation on the ground. That's why I just don't want this hanging around as if this is our start point again or end point again.
So
this is how the Feds got in trouble. So I want to avoid that.
Okay, so should we take a look at this? How you want to put it off? What, till the next meeting or 2 meetings?
Put what off?
Or did you want to close the existing public hearing that we have?
I can create the problem, but my solution was my main concern is to keep a hearing open where the team at the school have spent a lot of time, both at the school committee level and Dr. Dr. Clenchey's group has spent a lot of time and effort working with staff and all the rest to try to get this done. And now comes along this particular variant, which blows everything up, not just in numbers, but also circumstances. Okay. And I just want to make sure that we don't saddle all those people with basically have to start thinking about unwinding as opposed to, wait a minute, we have to look at this differently because I hope whatever they've done in the past is perfectly useful. I just don't want to keep something out there that basically automatically, because we've already done it, becomes the start point. We have to start saying, no, we got to throw this out, put this in. In other words, a whole new exercise.
Yeah, no, I think we've established a good framework for which to work in. And
well, there's where I disagree. I think that's maybe it's worth having another meeting and discussing it. I mean, I just don't. I'm very concerned about making sure that, especially at the school committee and at the and Dr. Clenchey's team, goes in there with I don't want to call it open mind because I don't think they're closed-minded, with basically ready to look at a fresh situation and recognize the features of it.
I'm sure they're well aware of what's going on. I mean, they know it's a fluid situation, and they're in the trenches. Dr. Clenchey, thanks for joining us tonight. I know you came here, and I'm sure you're looking to get something out of this meeting tonight. And tell us what you'd like to talk about, and we'll take next steps.
Sure, thank you. I agree with Mike. I mean, we don't know what's going to happen in the next 3 or 4 weeks or 5 weeks, and the conditions that we've drafted may or may not be applicable at that time, and we may be looking at fewer restrictions, depending on what happens in terms of certain aids that are available to offset the effects of COVID-19, et cetera. What I was hoping for, I mean, we looked at the conditions and we just made 2 changes that made sense, and I just wanted to make sure that the Board of Health also was on the same page as us. And I talked at the very end of the last meeting about the fact that people that have had COVID-19 cannot take part in pool testing for 90 days because we do PCR testing and they would test positive. We feel very strongly that if we went into a max flexibility trial and the conditions on the ground did not change, that those people would be able to take part in the max flexibility trial. And again, that's with the assumption that things would be similar to what they were before Omicron hit. And we know that's probably not the case. The only other one was trying to get a compromise here between the doubling effect, which I completely agree with in terms of virus replication. But also, as a school committee and superintendent, we still feel comfortable, or uncomfortable more correctly, that if we have 11 or more cases, we would not offer max flexibility. But we've incorporated the doubling component in there as well. So I'm hoping that kind of brings us more together on that component. And again, I'm not convinced that this will be something we'll be using in its entirety in 4 weeks or whenever we're ready to request another mass flexibility trial.
All right, so should we potentially just take a look at what is our February meeting schedule, Janet? Do we have one on the 9th? 9th, Feb 9th?
9th and the 23rd.
Okay. Dr. Clenchey, would you like to take a look at joining us at a meeting prior to February vacation or after February vacation? I know the DESI mandate runs through, is it the end of February?
That's the end of February. Either would be fine. I mean, it's difficult to predict when we're going to start seeing a slide in infections. I mean, we know it's going to happen. We just don't know when. So either meeting would be fine with me.
Okay. Why don't we take a look at February 9th and, assuming we're under triple digits in townwide case count.
Sounds good.
Okay.
All right. Thank you.
So next we have,
Excuse me, Kevin, are you going to continue to the 9th then, or are you closing this one and opening back up on the 9th?
I would say just continue it, but Dan, you had your hand raised.
I just have kind of a housekeeping issue. So the motion that was passed was a waiver of regulation for high school mask optional, with specific dates of January 18th to February 4th. So that is the on record waiver of regulation.
Mhm.
So at this point, that waiver of regulation really isn't applicable, that it's not going to be able to be used, or the applicant, the school department, is not going to utilize that waiver. From a housekeeping perspective, should we rescind that waiver of regulation, get it off the books, so that we can still use that historical knowledge and experience, so that when the school department is ready to go live again, we're not starting from scratch, and we can, again, I know Mike, recognizing that who knows where we're going to be tomorrow, next week, February 9th, 23rd, but just from a housekeeping perspective, that waiver of regulation really is no longer applicable and will not be utilized. We wanted to clear it from the books.
Because it had the dates called out in it.
Right. So there
Right.
was
Okay. Yeah, sure. Do you have a motion?
some agreed date, it was specific, and that's not going to be utilized. We just want to clean that up.
Okay. Do you have a motion?
Make a motion that we rescind the waiver of regulation for high school high school optional masking as voted on at our, oh gosh darn it, December 15 meeting.
I'll second that.
Roll call vote. Gino Fratelloni? You're muted. Still muted.
Right, yeah, okay,
There you go.
got it, thank you.
So Gino, do you vote?
Yes,
Dan Kane?
And Kane, yes.
Matt Wason?
Matt Wason, yes.
And Mike Zeldin?
Mike Selden, yes.
And Kevin Baker, yes. All right. So we'll see you February 9th, Dr. Quincy.
All right, thank you.
Thank you.
I'm sorry, Kevin, can you just formally take a vote to close the public hearing then?
Sure. Motion
you.
to close the public hearing.
I'll second the motion.
Gino Fratelloni?
I second it too.
And Dan Kane?
And Kane.
And Matt Wason?
Matt Wason, yes.
And Mike Zeldin?
Mike Selden, yes.
And Kevin Baker, yes. Sorry, Janet.
That's okay.
Yeah, Janet.
So we have a discussion, correspondence, public input, and potential vote on public health, COVID-19 public health items. Continuing the emergency regulation of the Littleton Board of Health, the mask mandate with potential amendments. Does anyone have comment on that?
I take it we are going to discuss the value of and length of extending the mandate further.
We can, if you'd like to talk about that.
Yep, I think, or if I guess we have to operate at the pleasure of the board. I mean, I'd like to see, I think we have good reason to extend it at least to the point where we are still in sync with DESI. So that would be the end of February.
Is that a motion?
I'll make a motion that we extend it to February 29th. There is such a thing this year.
I don't think it's a leap year.
Oh, okay. Thank you, Dan. I mean, I'm working on Webb telescope time. Anyway, yes. Okay. Same date as DESI.
All right. Is there a second?
I did second already. Am I mute again?
Oh, you're fine.
All right. I'll take a roll call vote. Gino Fratelloni,
Yes, sir.
Dan Kane,
Kane, yes.
Matt Wason,
Matt Wason, yes.
Mike Zeldin,
Mike Selden, yes.
And Kevin Baker, yes. So Janet will revisit that at our last meeting of February, which is the 23rd, you said? Okay. And then item B, issuing mask mandate violations. I know there's been a number of correspondence. I think another one came in today. So, and I know Jim's not here, and he would be the one to issue any citations regarding violations for repeat offenders.
He has been going out, Kevin. I spoke with him yesterday afternoon. He has visited all of the locations where we have received complaints. And, you know, as I'm sure we've all found, when he goes in, often people have their masks on, employees, and occasionally there's people who don't. But he has had conversations with the managers in each of the locations. But at the times that he's gone in, at least he's finding that there's large compliance.
There's a what? I'm sorry, I didn't hear that.
Large compliance.
Largely compliance. You know, that there's the occasional person who's not, but he's not walking into Subway or Mobile and seeing absolutely everybody without masks.
Yeah, the difficulty here is that it's the employees who are really, you know, really, not only they're at risk, but also the public's at risk if they're not fully protected, or at least have the mask, but if they don't have the masks available to them. And the popular places are especially of concern. And I'm just wondering if I'm just asking whether or not anyone here with experience feels that putting more teeth in the way of dollars and how much it would cost to be in violation after, you know, 2 warnings or whatever. I think that one of the sites have been, shall we say, mentioned more than once, and does it really require Jim driving in his truck with the license plate and all the rest in full display without blowing his horn? I'm interested in catching anyone. It's just that it's the employees who are basically going to end up being caught at the end of, you know, the short end of this. So I'm just wondering if it's worthwhile to consider taking more, shall we say, more proactive in places that have more than 1 or 2 complaints.
Yeah, I mean, I think that probably, you know, when Jim goes, he probably doesn't speak with an owner. I don't know if he speaks with a manager, but, you know, he sees employees or people, patrons in there, you know, with or without masks. I think probably the most effective thing would to, you know, let an owner know, or a manager, you know, what is it, a $30 ticket? I mean, that would probably just, you know, get their attention, and just maybe have their employees be conscious and wear masks, or instruct people to wear them when they come in.
If you think $30 is enough to stop them.
No, I don't, but at least it's, you know, at least it's actually going to get to the right person who can inform people and implement rules.
Okay. Well, let me turn to something that's a little bit related to this, but is of concern. And that is that as this particular variant races around, staff at restaurants and other public places are going to find it harder to maintain what I call minimum standards of cleanliness, not because they're derelict or anything, it's just that there's few of them and lots to do. And I'm suggesting that we should ask Jim to undertake restaurant inspections of all the places where food is served and where they're subject to public health regulations, to make sure that even though we are going through this, that we cut off people who, you know, stopping in for a quick bite to eat are also not getting sick from other things.
Yeah, I mean, that should be a part of the standard practice to do the food inspections. I know they just hired a new food inspector over in Neshoba, so hopefully we can steal some.
Yeah, I'd like to formally request that we ask that to be done. Okay. With it, you know, starting as soon as possible. All the major sites. I think it's time. Unless someone here feels that this is too draconian.
No, I mean, are you making a motion?
Well, to me, it's common sense to say when the staff is, I'll make a motion that we request Jim Gareffi to have to basically to undertake inspection of restaurants and other eating locations in town, in Littleton, as soon as possible in the next 2 weeks.
Dan?
I just being realistic, I'm not sure what our official list of licensed food service providers here in town, but I would guarantee there's no way that he can.
There's 78.
Can visit all 78 and do an adequate.
No, I think he can hit all the ones along the, shall we say, the main throughways. That would be, we could restrict it to, let's say, King Street.
Well, I do agree that we should have our food inspection services happen. I think there's a food inspector in place. Neshoba's hired to make all those inspections. We can certainly have a conversation with Jim about when that's all going to happen and when it should happen. I don't think under this item of issuing citations to people that are second and third time offenders of not wearing masks in public locations inside. I don't think that this is the proper place to make that food inspection.
I just disagree. Okay. I strongly disagree. They're two separate issues. Okay, two separate issues. And I agree that asking for people to wear a mask and enforcing that is an endless whack-a-mole job. I agree. But keeping the eating places clean as possible to make sure that and understandably that some of these places may be understaffed, a lot can slip, and the next thing you know, we have other things going on in town that are not appropriate. Two separate items.
Can we perhaps make a request? I know I certainly have, not even a year on the board, but I have not seen an updated list of how recently our inspections, I know early on we requested activity reports from the associated boards of inspections that are done each week or each month, what their outcomes are of those inspections, and we haven't seen that. Can we perhaps just ask Jim and his team for, our list of licensed food service providers and when they were last inspected as a starting point, or certainly if they're last inspected and any meaningful findings or citations for those. If we find that, we're at 80% have been visited in the last 3 or 4 months, which should be every 6 months they should be visited, then that might be different than because of their workload, they haven't been to a number of our establishments in a year or longer, then that's something that we certainly should be following up with them, saying the standard is 6 months and you are or aren't meeting it. But then we actually have some information we can work from. If they've been to most of our facilities in the last 2 or 3 months, then they've been in a bit of the meat of understaffed, overworked, and been able to address some of those. But maybe that might start to that point to try to avoid any other potential Board of Health responsibilities that can be.
Certainly a great place to start. Yeah. Janet, could you have Jim provide us with a log of all the inspections at our January 26th meeting? Thanks. And in regards to the violations, I mean, I don't know about you guys, but I'm tired of seeing the emails. I'd say like a third, fourth time, repeat offender, we should just issue them a ticket and just get their attention, and maybe they'll change their practices. And if not, issue another ticket. So I don't know if there's the appetite for that, but I'm tired of the emails. I don't know about you. So if there's a motion, someone should make it, or we can move on.
I think we already have structure in place for, violation of a regulation that Jim can apply. It's the biggest piece always with public health, both for health inspections, for food service inspections, and for home inspections, is really around education. The stick of
right.
Always the last often the least effective, although this definitely gets the most attention piece. We're limited in what we can do with education. We can send out messages, we can talk to folks. Jim is not in town. He worked really, really hard, and his team worked really, really hard, but they're not driving around town every day, doing their thing, doing inspections, getting lunch in our facility, in our places, or going shopping in our stores.
Mhm.
So, and other communities may have those folks in town all the time. That other opportunities, perhaps. I know, the police department does not want to enforce, or they are empowered to enforce all town regulation, and they've expressed that they don't want to participate in enforcement, which I understand their perspective for that.
Mhm.
But that does not necessarily take away their opportunity to provide education. The same way that, hey, fix your brake light. I'm not going to give you a ticket, but fix your brake light. Check your inspection sticker. That there's that opportunity for education from a law enforcement perspective, someone in a uniform in a car, where it carries a little bit more weight, perhaps, than a random resident coming in saying, "Hey, wear your mask." As our police officers are traveling around town, walking into places, doing the whole, "Hey, mask, check your mask." Not necessarily every time, but that opportunity to have extra sets of eyes and extra set of input in our community may be an opportunity that we can work with the department, recognizing it is not, we don't want you to write tickets, but simply be an extra set of eyes and be a reminder. Someone with a uniform and a badge giving a reminder that this is a town regulation and the expectation carries perhaps a little bit more weight than Jim trying to get a phone call or an email and being here in maybe a few hours, or maybe not until Friday, depending on what their schedule is. I'm not sure the best way to see if that's an opportunity or an option that Chief Bernard and this team would be willing to do, but it may be an option that we could look at. I'm not sure we don't have many other direct outreach opportunities.
I mean, the other option is, when we get the information, we can potentially have, Janet send them a citation, give them some information, mail them a pamphlet of some educational information on day 700 of COVID, or we can, send them a ticket. So, I mean, Janet, I don't know if you have the capacity, time, but that might just be, an easy solution for the repeat offenders who we keep seeing their names all the time.
Sorry, I didn't jump into one. That's a big ask for Janet. The other piece is, I'm not sure we necessarily want to take enforcement action from a resident or a citizen complaint without actually having an authorized agent making the observation.
Mm-hmm.
That piece of, oh wait, I don't like such and such, so I'm going to say they weren't doing blank.
Right. No, I get that.
Maybe somebody mailed me a ticket. That's not necessarily the best, probably. That's probably not a supportable process.
Mm-hmm.
As opposed to having Jim, who's an authorized health agent, or some other authorized authority, recognizing a violation and then taking action or choosing not to provide education is probably a little bit more sustainable from an operational and regulatory perspective.
I agree with Dan's comments on somebody official really helps to convey a message. I think if a police officer tells you that you're doing something wrong 3 times in a row, hopefully you think it's going to get serious pretty quickly. I also think in this position, because I think a lot of it is attitude based and not necessarily something intentional, but should we go the route of saying, if we get a complaint, should we reach out to the manager, owner, et cetera, of the establishment and just say, good day, we've gotten this feedback from town residents. Are you having trouble? Are you having trouble securing masks? Is there a problem? Are your staff having trouble? Help us understand what your problem may be, because maybe we can help.
Right.
And if their response is flippant at that point, then I think we have to go down a stick road. But if we could maybe try to approach it in a kind of a community mindset to say, hey, we're all trying to help each other here. Is there any way we can actually help you?
That makes sense.
Yep. I think that's a great idea. Do we have any public comment?
George Sanders.
Can you hear me, Mr. Chairman?
Yes, sir. How are you?
Pretty good, thank you. Just wanted to make a comment with regards to the mask. I think one of the big places that I've seen people coming in has been at our gas stations. There's a tendency people just go in without the mask. I mean, I've been inside down at the lower end of King Street, seen people come in without the mask, going to the pizza place and Dunkin's. Been up in the upper part of the common area and seen that as well. They come in and the sign is on the door, but you know, the people there don't tend to say anything to the people about you need to get a mask, you know, before they purchase this or that. So I think one of the ways maybe to deal with it is maybe public wise is put out a public notice that businesses are being asked to encourage to help enforce and keep, you know, everybody safe, your employees and the people that are busy, that are participating at your business there. Let's try to help everybody at the same time. Sometimes, you know, I guess you have to pick your battles, you know, as to what you want to do. This is something that shouldn't be taken lightly. And I think that a lot of the owners out there should be made aware this is something that shouldn't be taken lightly. And that you're basically trying to help everybody in regards to this. This is something that we don't want. And the more we help each other, the better off I think we all will be. But I think in some aspects, the employees that are working, they're not saying anything. They're taking the business and letting it, you know, skip by them. And I just think that something needs to be sent to the business out there and ask them, let's help the town to stay safe and inform your workers where that you got people that are coming in on different shifts that are working in these facilities and help everybody out here. I think that would, you know, fine is okay, but, you know, it's something that, you know, it's sort of kind of hard to enforce, and you got really one authority that's running in the various communities here, and he can't be everywhere at every time an incident happens or what happens. I just think that, you know, maybe we need to ride on the businesses, on the owners, and get them involved, have them to check, and maybe do spot checks at their location where their people are working, and sort of kind of help the situation out.
Yeah, that's along the lines of what Matt Wason was speaking of. You know, give the owners and managers some correspondence, and you know, see how we can help them. You know, I think that'll go a long way.
I thank you, Mr. Chairman.
Yeah, thank you. Any more public comment?
Yes, I have Justin McCarthy. Oh, shoot. I just promoted him by mistake. Sorry, Justin.
Sure, no problem. Justin McCarthy, 7 Stony Stream. Can you hear me?
Yep.
Perfect. Thanks for the discussion tonight. Just had a couple of questions. I had seen a previous agenda posted that had specifically talked about perhaps a concern at one of the local establishments, a restaurant. You guys didn't mention it tonight. So I just want to make the observation that it sounds to me like you're planning on performing health inspections, perhaps kitchen inspections, to maybe pick on those that have poor mask compliance. But there was an earlier agenda that had an establishment listed and a rodent problem. So maybe you want to clarify that for me or possibly for others. Do you in fact have concerns about the cleanliness of some kitchens in town, or are you simply looking to make some establishments jump through additional hoops that potentially have poor mask compliance?
We're mandated by the state to conduct inspections of food service establishments throughout town. I don't think there's any real great concern. I mean, we do get the occasional email from time to time.
There was one listed on the agenda previously. So as a resident, I was just curious about that.
Which one was that?
The tavern.
About the rats?
Yep.
That's on tonight. That's right after this.
Okay. Okay, great. My other question, so we'll talk about that soon. My other question is, why does the Board of Health want to mirror a townwide mandate in conjunction with what DESE is saying? DESE is basically saying that if you don't have 80%, you're required to mask through February 28th. However, if you do have better than 80% vaccination status, you can apply for a waiver. So why are all of the establishments in Littleton subject to DESE's rules? Are we running a townwide school system here? Like,
No,
what's going on?
That's just the date Mr. Zeldin proposed.
But why is it mirroring DESE? Like, the Department of Public Health, Massachusetts, has a recommendation, not a mandate. So why do we have a mandate that mirrors DESE?
Why is the date the same as when the DESE mandate
Correct.
expires?
Multiple times now the date has matched.
I think it streamlines everything. I don't know. Does anyone else from the board want to take that?
Sure, I will, because the suggestion again, Mr. Chairman, is unfortunately the school here is, the town is not covered in a bubble. And at least the last time I checked, it may be different later, but right now we are wide open. People pass through us quite readily. We're part of a very large community and the school is part of it. And one of the reasons we have the mask mandate in town is to do what we can to mitigate, to take whatever advantage there is available through masking to protect people when they're indoors in indoor establishments. And the date chosen is to make sure that administratively and health-wise, we're not out of sync with one of the major places where, very frankly, very important people in town spend 5 days a week at least. And how many hours of school? I mean, that's being indoors. So it has to do with, again, mitigation and protection.
So if I understand you correctly, all of our retail establishments have a mask mandate so that the schools continue with a mask mandate. I mean, that's your interpretation of what's going on. I'm saying that the reason that all establishments have mask mandate for indoor, if you're indoors and you're in the establishment, you're supposed to wear a mask. One of the establishments of key in this town is the schools. As far as I'm concerned, what we're doing here is trying to address, it's not a movie theater. The school is a major place with some of the most vulnerable people in town. So that's not true. So the children are actually the least vulnerable. And Mike, you obviously know that. One of the things I would ask all of you to consider at your next meeting is a topic of one-way masking. So we no longer are in a situation where your mask protects me and my mask protects you. We all have access to vaccine. So if you are a double vaccinated, boosted individual wearing an N95 mask, you don't need anyone else wearing a mask. If anyone has a mask on, it's actually not lessening the risk to the individual.
I'd just like to interrupt and basically say that, Mr. Chairman, do we have 2 minutes for this speaker? Because we're wandering into
I think
areas
it's a little
of
discriminatory
interpretation.
that I have 2 minutes when other speakers
Yeah,
have
let Justin finish. Let Justin finish what he's saying.
Thank you, Mr. Chairman. Mr. Zeldin, respectfully, I do think that you folks need to advance the conversation here. It's very clear that you are reverting back to the 2020 playbook over and over again. If you look at where the cases are and where the hospitalizations are and where they're going to be in the next couple of weeks, you're going to see a clear decoupling, especially when you factor in vaccinated versus unvaccinated. So I am asking you to keep an open mind at your next meeting. And the reason why you have poor compliance is because your policies, your public policies at this point in time were put into place way too early. I wasn't wearing a mask when you first put your policies in place. I am now, and I hope to not be in a position to need to wear a mask in a couple of weeks. And my fear is it'll be months, or longer, that you guys are going to want a mask mandate in town. So I'm asking you respectfully to please keep an open mind, consider the data as it's coming out, and don't simply revert back to what we were doing almost 2 years ago. Okay?
Yeah, I think we'll continue to keep an open mind. And, we see a number like 293 cases in Littleton.
How many hospitalizations do we have in Littleton?
See, we can't find it out. I wish we could
The
find
other towns have that data, and I'm wondering why we don't have it.
What other town has the data? Please tell me.
Billerica. Go to Mr. Kane's Facebook post, click on the mask mandate thing, click on Billerica, and it'll tell you that they have one hospitalization. Other towns have it. A couple clicks, you'll find it. So case severity is way down. Keep an open mind. You have great authority, and with that comes great responsibility. I know that sounds, a little strange, but I'm asking you folks to be progressive with your thinking, and please don't just hold. Businesses are struggling. You're taking money out of business owners' pockets every day.
Yeah, Justin, you had sent me that article about Stoneham and how they've issued the mask mandate for essential places like grocery stores and pharmacies, and
only grocery stores and pharmacies.
And I think that's pretty progressive.
I think that makes sense too.
If you don't have to go somewhere and you don't want to wear a mask, don't go. But regardless, we will certainly keep an open mind. Thank you, Justin.
Thank you for your time.
Is there any more public comment, Janet?
George Sanders has his hand up.
Yep. Hi, go ahead, George. Oh, is he up there?
Now, can you hear me?
Yep.
Okay, George Sanders, 672 Great Road. Mr. Chairman, I just sort of kind of just want to echo something here that I think that it's important that people understand that this virus is something that will kill people, and it is your job as a safe net in this community to protect this community the best you can with people living in it and those that are coming through it. And I think that to coincide with a date of something else that goes on with the school or whatever the case is, this or that, you come up with a date. Why is it that we have residents thinking that you're not thinking smart here and that you're not concerned about wearing the mask or not wearing the mask? You are concerned about it. You're also concerned about the people. And there's nothing other than I know of that you should be more concerned about is the people. And I just simply think that what you've been trying to do, I think that you've been doing a good job at it. There's going to be those that are going to criticize you for what you try to do. But I think the long or the short of it is, those that don't want to wear a mask, and they come down and get sick and they die, well, certainly I wouldn't want to know that the health board didn't do their job in terms of trying to protect everybody here in this town. This is something that is upon us, and we must take it seriously. And I say, what you've been doing and the advice that you've been given and whatever date you come up with, you know, I'm here to say I support you. And I know a little bit about this virus stuff. And I know that we have got to do the very best we can in reaching out and protecting the people. And I want to thank you, Mr. Chairman.
Thank you, Mr. Sanders. If there's no more public comment, I guess we'll move on to our 8:30. I'm sorry, 8:15. We're running a little late with Michelle.
8:10, Kevin. The tavern.
Oh, 8:10. Sorry, yeah. Justin's waiting for that. So yeah, we have other correspondence from Mr. and Mrs. Cornetta regarding rats from Tavern in the Square going to Chicory Road in Westford, which I'd imagine is right up the hill. Janet, do you know if Jim has gone over there?
I do. He has had several conversations with Mrs. Cornetta. He's gone out to the Tavern on the Square and taken a peek at their dumpsters, which he found to be clean and empty. So when he spoke with Ms. Cornetta, she said she thought maybe it was coming from O'Neill instead. Jim said, you know, not as clean as Tavern, but not horrible either. So he's been in contact with, there's a new project manager over at the Point, and he's been in contact with him. I guess the dumpster inspections have had less frequent occurrences during the period of COVID, but he's stepping up with it. Jim is also working with the public agent, the health agent over at in Westford. So it's still ongoing. Nobody seems to really understand why the rats, if there were dirty dumpsters, would leave the dumpsters to go up the hill.
That's a big hill.
And if there's food and stuff at the Point, why they would leave to head elsewhere. But he has been in communication with multiple people, including the resident.
Okay. So I guess just keep us posted on if is it Mrs. Cornetta? Miss Cornetta?
I'm not sure. Joanne Cornetta.
Joanne, okay. If she needs any correspondence from the board, just let us know.
Okay.
Thanks. Hi, Michelle.
Hi, everyone. Good evening.
How are you?
I'm good. Thank you. How are you?
Doing great.
Good.
So Michelle's here to talk to us about, she's the Human Resources Director for Littleton. And she's going to provide us with some guidance regarding the proposed job description. I've included the job description in our packet that was put before the select board's Monday night meeting. I wasn't able to attend, so I don't know the outcome of that, but I'm assuming. I know, Mike, were you in attendance Monday night? You're muted.
Yes, I was there. And I think Human Resources has got a lot of things on their plate. And I think we've probably handed them, or what's been handed to them is a real tough one. I think this is probably one of the most difficult. I don't think we should take credit for it, but this is one of the most difficult things to do, this particular position, because there's, I think, as will become clear later, perhaps a lack of clarity on the part of various interested parties, and I'll call them observers and stakeholders. So I'd like to, first of all, thank her ahead of time. And number one, that to understand it's going to be an interesting ride, but we hope to get to the finish line. The other group that we have to be in touch with is to make things even more interesting will be also the, I'll call it the finance department, so that we can make sure that whatever we're heading into includes, as shall we say, a comprehensive and as complete view of the financial consequences and meaning of what's about to occur.
Okay. So Michelle, the floor is yours.
So thank you, everyone. I haven't met all of you, and if I have met you, you've probably only seen half my face. So because I do wear a mask. So thank you for all of your hard work. And as Mike has said, there's a lot going on in the Human Resources Department. I have only been there for 4 months, going on 5, but it's been quite the whirlwind. So this was kind of given to us, and it was explained, and I do want to apologize to you, Kevin, ahead of time for relaying the incorrect process to you and how we can go about posting this. We are trying to move fairly quickly. However, I do not want to rush. We want to do it right. And I think we have a good start. Obviously, it is a work in progress, but I do think that we can hopefully post this sooner than later and get this going before town meeting, before the deadline hits with Neshoba. So what we have done to date, Ed Mellon and Janet have been extremely helpful to me. We did reach out to the MMHR listserv and pool other cities and towns for their applications for not only the health agent, but a public health nurse. And we were able to pull together not only salary ranges, but job descriptions. Ed was kind enough, and Janet, to pull those together, kind of build what they think is the need right now. Kevin, I do know that you have looked it over, and I know it's been in your packet for this evening. So as I said, we did bring this to the select board on Monday. There were no formal changes, minus the fact that Ed and I did speak together about the public health nurse. If you look at the end of it, there is a section that says it more goes into, special requirements, posting. It's more posting requirements. Actually, it's on, it's on the health agent one, not the public health nurse. It goes into salary and benefits and the application and selection process. That doesn't typically get put onto a job description, so we will be removing that and breaking that out as a separate posting. But for the most part, in looking over both of them, they do look, as I said, you can always change a job description. You can always add to it. It looks like a good start. It looks like a good structure. I don't know if you all had anything specific you wanted to see added to it. Mike, I know you had spoken about, the local versus what's in town and out of town. I listened to that portion of the conversation and the local constraints. So, there's a lot here. There's a lot, like I said, you're never going to capture everything in a job description, but at least we have a strong start to where I think we could post it if you're all on board with them and see them as fit right now.
Mr. Chairman, you can cut me off anytime because I've been pursuing this for a couple of weeks now or months now. And this is not on Michelle. It's not an area necessarily. I don't know how much exposure any HR person gets to something as specific as this. This has certain specificity. This is, if we said, hire us, a qualified MD, it would probably be a snap. Okay. This is more difficult. I've run yours and a few others by some real Board of Health directors, that is, who have responsibility of the type that this board is interested in, at least as I understand it. And what was glaringly missing, and this is no fault, it's just a comment, and it permeates the thing, is that public health is it never mentions the fact that one of the major jobs is prevention, not just mitigation is an emergency reaction, pretty much along what a hospital does or what a doctor does. Public health has a lot to do with prevention. And the three, shall we say, pros I showed this to saw it almost immediately, that the thing that was missing here was the lack of emphasis on the importance of, shall we say, dealing of prevention, of looking over the horizon. I'm not suggesting terminology that has to go in, but it basically turns out to be more of a, in fact, the confusion was, are you looking for a sanitarian or are you looking for a real health director? So that there's a certain element here that I think the rest of the board will probably want to put it, have some input on, but it's a little unclear. The other thing that was mentioned to me is the fact that I'm not sure I would use the phrase cart before the horse. I'm not sure we have a horse or a cart yet. But in general, most folks who have responsibility for public health in the town want to make their own hire of the sanitarian. They don't want to be, and the reason for this is because the sanitarian operation has to be consistent with the other policies and programs of public health in the town. So there's going to be the issue of clarity here and what has to happen first. So to sort of say, this particular member feels that this posting should be focused on hiring a director of public health who's responsible for many of the things mentioned here. But one of the responsibilities is basically the appointment of or the selection of a sanitarian. In other words, the hire is for a director who in turn is responsible for staffing. And one of the staffings would be nurse and sanitarian. So we have a problem having to do with transition, which has nothing to do with affects your work, but we are concerned, at least some of us are concerned about this, about the, as it were, the cart before the horse, and which is the proper way to proceed in view of the peculiar circumstances in which we find ourselves.
Mr. Chairman, if I could just follow up on that for a minute. So, speaking from experience, and I will say, Mr. Zeldin, that HR does get specific sometimes, but you can only go so far. For example, if I have a job description for a firefighter, I'm not going to claim to know the ins and outs of the fire department and what they do.
Sure.
So, it is best to reach out to experts and who do it daily and who see it daily. Even though they don't know your town or the needs of the town, they can at least give some input. And I do want to say that I can speak from experience a little bit what you're speaking of with the director. I think, just in my position alone, the town had evaluated what they needed for an HR department. They thought, an HR manager would be sufficient. And then as they went on, they realized we need a little bit more than this. So they had started, kind of put that cart before the horse, got things going, and it just wasn't enough. So I don't know. I know this has been going on a long time. The reorganization for the building department has been going on for a year. I don't know how deep it's really gone, but I don't know how much the needs have been really looked at of is there a bigger need for a director to really take on this stuff.
Mr. Chairman, I'm not the only person here who's thought about this. I'm pretty sure everyone else here has given some thought.
Yeah, Mike, I would say something. I mean, obviously, I'm relatively new to the process as well. I don't have the back history. It's been going on a year, but I'm fresh to it. But I know it was bantered about and say, well, do you hire this sanitarian first, or you hire the director first? And I think if we go the route of trying to hire a kind of lower level position, we're going to have to overhire them, because we need to rely on them so much if that's our only person, especially since who will they be reporting to and what expertise does that person or group have to help a person who has to operate very autonomously to meet all our needs. The flip is, well, you hire the director first, but you really ask them to be a working director because it's all we're hiring right now. And therefore, you're probably also going to have to overpay that role too, unless you can find the person that is really excited about building this up. because I'm sure it will scare some candidates away just knowing that they're coming into nothing to start.
Yeah, I mean, I personally like the idea of the working director, like someone who can get down in the trenches and, and go and do the soil evaluations or do the food inspections, but also have a sort of top line overview and, clear direction on building a department.
And I feel like the job description thus far has tried to weave between the two. And I think that's part of my struggle with it, is that I think to myself, well, if it's this one, it goes this way. Otherwise, it needs to go another way.
So, Michelle, would it be possible to sort of make it a little bit more clear and give it a clear direction?
Absolutely.
That we are looking for a health director, but someone who can work in the trenches, and someone who has the ability to do the soil evaluations and knows Title V and can do the food inspections and has all those qualifications. I think that and really is passionate about it and has the wherewithal to build the department, given the necessary resources.
Yeah, we can certainly go in that direction. And, just speaking again from my experience, that's what I'm doing, right? So I'm highly involved in the benefits and in the weeds, right? In the daily grind that the benefits coordinator needs to be doing. And we're both doing it. But it's because we need to build the department. It didn't exist. And you've got to start somewhere. But now we have that room to grow, to really pull me to those bigger issues that need to be taken care of. And then you have the worker under you that can still keep it going. So when you are trying to build a department, it really does make sense to kind of look at a director. It's just if you have the appetite for it, and you obviously have the funding for it. So we need to figure that piece out. But it's a matter of looking at what are we really taking on from Neshoba. And as Mr. Zeldin had mentioned, before in prior meetings, it's, we're not just taking on from Neshoba. We're looking at what's going to happen in the future. Nobody has a crystal ball, but it's more than just our town. It's more than just an inspection. It's more than that. So I don't want to see you get into a spot where it's like, well, we only hired a health agent. They're not really qualified to do the work you're talking about.
Hi, Mr. Mullen.
Mr. Baker, how are you?
Doing well. How are you?
Good, thank you.
And I do, sorry, Ed, just to follow up, I do want to say we are bringing this back to the select board on the 24th at their next meeting.
Yeah.
And we will be working. So we do have a rating system that our former personnel board did use to rate the positions. Kevin, I know you had a hand in looking at that and tackling that. There are more ratings that need to be done, but we now can go back to the drawing board, pull together a health director and redo that portion of it. But I don't see it being something that, needs to be rushed or forced through. It's not something that can't be done, within the time frame needed, I'll say.
What do you consider the time frame needed?
Before June. So when I say that, it's before the deadline that, we have the contract up with Neshoba. I know I think March was thrown out there before by some folks, by some board members. So it's a matter of making this a high priority when I know it needs to be. And unfortunately, other things get pushed off. I mean, it is what it is. And you learn as you're on the job of what that can be. So this is a high need for the town. We are in a unique, I'll call it, time period with COVID and everything going on. You don't want to let something like this slip.
Yeah. And the other thing, again, this, it's not, it impacts what you're doing, but also the fact is that we don't know yet whether or not we're going to need more time than the time may run out in June. I just don't know. I mean, right. Judging from the burnout rate, I'm not sure we can. It would be very nice if we could hire a director before June, or at least have identified one with an opportunity. That person should be qualified enough so that, very frankly, because I know for a fact that it's going to be very difficult for Jim, given what I think is coming for him during this period before June, that he will not be available to assist us in the manner in which has been mentioned by several times. It's probably not going to happen. So whoever comes in is going to have to be able to not only, be the quote quasi director, but also be prepared to do what Jim has been doing for the town, along with everything else, without little or no, assistance, or the input will be minimal from him. And also, there has to be a person who's more forward thinking than some of the folks who are getting burnt out and basically getting consumed and are near, basically had enough and are leaving the profession, as it were.
That's a good point. I mean, there are, if you go on MMA, I'm sure you've seen the jobs that are open in every profession, but there are a lot of health agents. And so I think posting for a director is a lot more unique to this town and eye-catching. Not only a director, but one that's building a brand new department that can be quite attractive to the younger generation that's up and coming, and even the older generation that has, maybe become to a point where they've built their department and they're kind of at a stale point. So I think that's a unique thing we can offer to the market. My friends at CDC said, take all the, never mind. They just, it's not, that's maybe the generation they want to avoid. I won't go into why. It's their problem, but it percolates down because we don't have, the U.S. has a lousy public health system. Let's face it. So but it's attractive for the town to. Oh yeah, sure. Hey, we want you to build this department. We don't want you to just come in and be a worker. Yeah, and by the way, just I'll stop there, and hopefully Dan and others can chime in, but. I certainly hope your plus minus next to $80,000 goes up a bit.
Mr.
Chairman. Yep.
If I may, Mr. Chair. So thank you for allowing me to speak. I want to let you guys know I did go to the FinCom meeting last night where our finance director was giving a budget update for the upcoming budget meetings. And there we spoke about it a little bit. And the good news is one, it looks like it's a possibility to upgrade the position. Two, I also spoke about some of the things that Mr. Zeldin said during the select board meeting where we needed to be a little more forward thinking and thinking about public health in a broader picture, not just looking at the sanitarian side of things, but, because perhaps the sanitarian side of things where there's permit fees and plan review fees, that it can offset some of the cost of hiring an agent. But if we wanted to move it to a director, that the funds are still there. It's a bigger ask, but I think it's something that we can push through because of the importance of the role. And I also spoke with the finance director tonight before this meeting, just if we are able to bring somebody on board before June 1st, looking for funds. And she said, absolutely not an issue through ARPA. There's plenty of money. She's looking for us to spend a little bit of it. So that the funding side of things to bring in a health agent, should we be able to get it? A health director, should we be able to get it done sooner than June 1? If we're not able to get the person on board before June 1 or July 1, really, there is a local retired health director here in town that is offered to mentor or help and assist in any way that he can. And then there's also a couple other agencies that I've spoken to, and I'd be happy to share their names. I don't have them in my mind right now, but they're available for infill services and or for assistance until we have that up and running.
Great. I feel like, if we can get a jump on it and get this back in front of the select board with any, edits for the January 24th meeting, we should be in good shape, right? To get it posted and get somebody hired for a spring start.
I don't know what numbers Ed has been talking about. I'm sorry, Ed, because to be graphic about it, the amount of dollars involved in this basically are, I think, not insubstantial compared to. Let's put it this way: they're not at the scale of the police or the cumulatively of obviously the police or the fire department. I don't know what. Maybe Ed could give us a hint of what he considers to be possible from his discussions, informally as they may be.
We could potentially move that number up to just under the $100,000 mark.
Yeah, this is my concern, and I'm not talking about reluctance on the part of the town to invest. It has to do with what the kind of talent or show abilities that are going to have to be here, given what's going to be happening to Littleton probably within the next 4 to 5 years, easily, just in terms of pure volume and population change. So it's well, all we can do is give it a try, I guess, and see what we get. And I'm in another part of the meeting. I'll give another, shall we say, a further view about the environment in which we're coming from, hopefully soon. That may help Michelle and others involved in this get the posting really cleaned up, as it were, to make it very, very attractive.
Yeah, I think that financial figure will work. I was speaking with someone who's a health director at a town closer to Boston, does a great job. He was just given a raise, went from like 96 to 106, like pre-COVID, then during COVID, just because he had so much more responsibility during COVID. So that number is, ballpark. Should work.
Thank you for allowing me to provide the update.
Yeah, of course. Michelle, do you need anything else from us?
I don't think so. I think, I have my duties, and I'll pull the listserv again and get their job descriptions for a director, and we can, Ed's been, like I said, Ed and Janet have been extremely helpful to my department, and we can pull it together.
Well, thank you.
When is your next meeting?
By the way, Michelle, don't hesitate to get in touch with me, because I got a stack full of other stuff. I don't have to share it with you. Don't worry, I'm not going to send you more paper. It's just
Thank you.
No. I'm not. No. If you just have a question about, shall we say, the duties, and that sort of thing, because there are areas that are, I wouldn't say they're new. There would be new to a director in this new era. Okay. Mm-hmm. Yep. That's been going on for at least 5 years or more. Okay. So.
And that's a good point, because I'm sure if I pull from the listserv, there's a lot of cities and towns that haven't updated their job descriptions since COVID, since, things life events have happened over the last 5 years. So that would be extremely helpful.
Yeah. And also there's a history of Massachusetts boards of health. It's one of the most fractured in the United States.
So does anyone on the board with any comments or additions or potential edits to a job description just want to send everything through Janet so we can all take a look at it? Our meeting's not until January 26th, so it's 2 days after the select board meeting. So we'll have to do this all electronically via open meeting law regulations, and it'll be a lot of fun.
Dan, have you got anything from your perspective?
I think, my piece is, again, that working director model. I think is going to probably provide us the most successful approach. Same way we use the model of a working fire chief, if they're looking at budgets and staffing, but they're also hopping on the ambulance or an engine in a pinch. That kind of piece, I think, is going to be really critical for us to be successful. That putting a working sanitarian in place without having support structure around them. Nothing against Ed. I'm sure he's going to be awesome, but just simply have the health skill set to be able to really both provide support and resource for the level of complexity that we're going to need without having the showbiz depth of expertise across multiple staffers that we're not going to place. And that sanitarian isn't necessarily even going to know what they don't know in some places. So that piece of, I'm glad that Michelle and Ed, and it sounds like, finance is all on board of looking at that working director model, which is one of my concerns early on as well, is going to be something they can do. I think that's the best, provides the best chance, the best resource for the town, but also the best vision for where you're going to be in 5 years. Having someone in that chair who can look at where should we be in 6 months, a year, 5 years, and what's realistic, and be able to sit at the table with other department heads and say, where can we work together? Where can we provide service to you? Where can you provide service to us? Also, I think is really critical where a working level sanitarian isn't going to be sitting in the budget committee meetings with the select board or finance. That's not going to be their scope of their job. So I think that's also pretty critical for us to be built out in the department. Even if it's a department of, 3 part-timers, it's still going to be probably our best chance of success. So.
Does any other board member have a comment before we take public comment?
That's fine with me. That's fine.
Okay.
Thank you.
Do we have any hands raised? Let's see.
Yes, Jen Gold.
Hey, can you hear me?
Yep.
Hey, Jen Gold, Harwood Ave. I'm calling as a resident, and I have 2 questions going back to the topic of the mask mandate and the waiver requested by the high school. So my first question is about the waiver. From what I understand, it's a little unclear, but from what I understand, it sounds like the waiver for allowing mask optional at the high school was rescinded. And what I heard Mr. Zeldin say was something about how the criteria have been obliterated, the landscape is different now. I'd like to understand more from Mr. Zeldin what you mean by that. From what I understand, the waiver that was requested by the school was, based on DESI guidelines of an 80% plus vaccination rate. And there were very specific criteria and conditions placed on that waiver around case rates.
Jen,
yes.
Can I stop you for a minute?
Yes.
We're talking about hiring of our health director in Littleton. If you want to go back to the previous sections, can we just wait until we're done with Michelle and then after our next board section to talk about that? Okay. Does anyone else from the public want to address the current topic of the health agent / director position?
I have George Sanders. Oh, I think
That doesn't look like George Sanders.
it does not. I'm sorry.
Not unless.
Let's see.
Okay, can you hear me, Mr. Chairman?
Yes.
Okay, this is George Sanders, 672 Great Road. I just wanted to say with regards to the hiring here, I think that a key factor that you need to emphasize in this application is that you're looking for a director that can build this foundation that you want to put in Littleton, which means that that person is going to have to be down in the trenches, as someone mentioned earlier there. And I think in order to probably have candidates to jump at that, I think that you need to put a range in terms of pay that this job will offer. And I think that I know that Mr. Mullins said that probably go up to 100 there. If you get a top-notch person that can come in here and do what you really want to do, I think that you need to move that range up a little bit more. I would say give it a variance here between 90 and 115,000. I think you'll be in better shape to probably pull some good candidates in there. And the thing that you're going to have to look at, and they said, well, don't worry about the money here because this money that came in from the feds. What you need to look at is whatever you come in and put in for a salary, you need to ensure that you're going to be able to pay that bill. Because this federal money is going to run out at some point. And we don't want the job to be where now we are crippling ourselves by putting in a certain amount based on the fact that we got this federal money. We should be basing that on money that we know that the town is going to be able to come up with and pay for this position, because once you get someone that can get in those trenches and get somebody in there, like someone spoke earlier about hiring the nurse, the sanitation person, then that director will sort of kind of back off once they get those people in place and become the supervisor of that. But I think initially you're going to have to raise that salary a little bit in order to get a good person that's coming in, that's willing and want to get in the trenches. Because a long time people ain't want to get into the trenches.
Yeah.
They want to get in where somebody left off. And we don't have that situation here. I thank you, Mr. Chairman.
I thank you. Yeah, and Michelle will do her due diligence. You know, she goes through various job descriptions and sees what else is out there as far as the applicant pool and other positions that are like-minded throughout the Commonwealth. We'll get a good range for salaries, and I'm sure we'll be very competitive no matter what we put out there. So, thank you. So if there's no more public comment on this topic, I guess we'll leave it at let's have board members put together any comments on the proposed job description that was in our packet, within the next, I don't know, I'd say 48 hours to get it back over to Michelle, and then maybe we can have a meeting prior to the select board, maybe a non-quorum meeting or something like that, just prior to the select board meeting to finalize things before it goes in front of the select board. Does that make sense? Okay. Thank you, Michelle, for your time.
Thank you, everyone. It was nice to meet you, and thank you for having me.
Yeah, no problem. We'll talk to you soon.
Take care.
So we're a little bit late, but we have a 8:30 board member updates, comments for discussion, and then we'll take more public input. We'll get back to Jen Gold too. So Mike, I know you had an update regarding the Neshoba Quarterly.
Yes, I'll try to make this quick and as painless if possible. I attended the meeting, which was focused on basically the budget for Neshoba, where they were facing the loss of Littleton come June of this year. The bottom line is that they selected a budget which continues the accumulation of debt on their part. They're still basically not able to, as it were, come out even, number one. And it's not just due to COVID. Apparently it's a structural issue and has been for a while. And they are basically trying to not avoid, but reduce the amount of dependence they have on their reserve. The level of detail provided by the organization to the members, those are the towns, is I would classify by my standards and Littleton standards as sparse. There's quite a bit of aggregation. I asked a sample question. How much environmental work have you done for Littleton? How much have you done for Pepperell? And they don't track that. They just put it all together in one happy pot. The other thing, all these are lessons that I think that we've got to take to heart when we move on to what we're going to be doing. The other thing that was very interesting to me is, although they were aware we were going to leave, I considered significant, maybe it betrays my background, but no one asked, what could we do to keep you? Because their budget is going to take a hit of approximately, I'm being a little bit conservative here, that is not probably giving the real estimate, of between 14 and 16%. And that's quite a hit for an organization that depends on contributions made from 14 or 15 towns. The other thing is that the difference in the, shall we say, the demographics and the resources available to the towns is quite stark. You have larger towns with reasonable budgets and are available and have an interest in doing something in the area of public health, and you have others that basically how little can they possibly spend, or more frequently, we don't have it at all. So, and also there's a rigidity right now that I'm sure could be questioned and attacked, but there's a rigidity that the main assessments that are provided to the member towns is based on population, not density, not condition. It's a very simple, oh, you increased your population by 2.4%, so your assessment goes up X, where X is based on your population, period. Not the need, not the density, not anything at all. And the towns, we're not alone, who are facing some growth that's not just simply linearly related to their needs for public health. What you run into is a lack of interest on the part of the town or the select board or whatever in doing anything about it. And the result is that they become highly dependent on Neshoba. The other thing is that Neshoba, in order to continue its work as an association, also acts very frankly as a visiting nurse operation for many towns that are not part of the district. So in other words, it turns out that Concord has employed them as a visiting nurse operation, and other towns. Nothing wrong with it, but they generate revenue from that to keep them, to help keep the coffers in operate. And these are all survival mechanisms that they've basically to do it. And the interest in making any sort of changes that would reduce their deficit, they're changing their nature of operations, including how they track things, is zero. So my sad news is that I came away from that meeting saying it's too bad, but we have a choice of spending time and energy trying to build a Littleton department, and or an effort to, as it were, take on making Neshoba stronger, because at the price point of Neshoba, shall we say, is in the order of, I think that somewhere between 48 to 52,000 at a max for us to get basically Neshoba services. And then I'll leave you with this thought. After discussion, it became clear that the new hires being made by Jim are by and large not assured beyond a certain, shall we say, fiscal year, maybe one, maybe two, because the state has not agreed yet to fund, or the funds have been allocated to retain some of the hires that he's made. So in other words, they're state originated funds. He doesn't know, it's not, without the state providing the grants for it, Neshoba could not afford to hire them. So with
maybe temporary positions.
They are, I'll call them semi-temporary, and I'm sure some of the folks are very competent. I mean, they're not, and they're training, by the way, sanitarian from the ground up. He will be, because I know he's a he will be probably let out by himself. I think this is the first year after 2 or 3 into the field. So I would say that the choices for us are stark.
All right. Well, thank you. That paints a good picture. Does anyone else have any updates, comments? Dan or Matt? Dan? Yep.
Nothing about Neshoba. Couple other outside of the board's responsibility, but certainly public health related. That as someone who works in 2 different hospital systems here in Greater Boston, I will share, certainly most folks have seen the news that hospitals are stretched beyond capacity, that the news reports are true and late. It's been this way for quite a while. So I would simply ask for anybody who is sick, get care. If you do not need to go to the emergency department, try to avoid going to the emergency department. Utilize your PCPs, utilize urgent care, utilize televisits, but certainly do not avoid care if you need it, but please try to utilize emergency departments for what they are truly for, which is emergencies. Hospitals are beyond capacity, and just like we look at schools, that since the beginning of the year in the schools we've had 153 positive cases in schools. I did the quick math. That means at least 460 days of kids out of school. Now imagine that same thing being in your local hospital, and that's your nursing staff, your dietary staff, your physicians, your PTs, pharmacists, and you've now taken that many folks, that many worker days out of a hospital in that same place, so that their bed space is tight, provider space is tight. That certainly looking at the hospitalization reports on the state website shows some capacity, not much. As someone who's working in the trenches, I will tell you that I'm a big believer in data, but I can also, from an anecdotal piece going, that is nowhere near as rosy as the state orange hospitalization dashboard looks. It's worse out there than that even as challenging as that looks. So please be thoughtful about how you utilize resources. Don't avoid care, but think about where you're getting it. The other piece going along with that is if you are able to donate blood, please do. American Red Cross is reporting they're down to less than 1 day supply between ability of folks to donate, willingness to donate. There's lots of great opportunities to donate. American Red Cross, you can go to their website. Emerson, most of the big Boston hospitals, UMass, all do blood donor programs. So if you are able and available to, please consider donating blood. Thank you. My clinician hat is off now.
Thanks, Dan. Matt, do you have any comments, updates?
No further. Thank you.
Okay. I just had one comment, and I realize the town, I think, is going to be receiving like $3 million in COVID relief funds, and I know that 2/3 of it's going to fund the sewer. But I'm wondering, Janet, if we can reach out to Anthony and see if there's any funds the Board of Health might be able to utilize to provide testing, at-home tests, and or better masks for our residents. I don't know if that's something that maybe I can send an email and CC you on it, and I can send it to Anthony and see where it goes. But
I can suggest copying to the select board chair as well.
Okay.
In fact, all members of the select board should be copied on that.
Okay. Got it.
And make it clear that you're looking for masks for the town, and not that it's trivial, but not just for the building.
Yeah, no,
that they're in.
No.
Yeah.
How many masks would you say would be nice for the Board of Health to have as a reserve supply for its residents in situations where they might need them? Just a ballpark. I mean,
I've seen numbers where the emergency reserve, maybe Dan's seen it, but I've seen reserves of up to 20 to 30% of the total population.
Yeah.
I don't know what Dan's I've seen.
You're muted.
I haven't seen a hard number, but I mean, I haven't seen a hard number, so I would be able to say certainly 2,000 to 3,000 as a reserve for a town.
Okay.
Something that's that small, disposable, and relatively expensive doesn't seem unreasonable.
And regarding the testing, I don't know if you all had gotten the email from Jim that he sat in on the conversation with the state regarding getting testing, and there's a number of towns in Neshoba right now who are interested in getting at-home test kits for their residents, and he's wondering how many we would need or want, and where the money would come from. So we'd have to ask the select board for the money, of course, but how many at-home tests, same in that same 25% of the population. So
that's a figure. And also if I'm not mistaken, although I'm not sure if this amounts to anything, the Biden administration either will be doing it this week or next, that the post office is ready to deliver. I think it's 1 or 2 test kits per household.
I read that.
And then you have to ask the question how the test gets used, because remember, it's a snapshot in time.
All right. So public comment. Oh, can we bring Jen Gold? Oh,
wait. Could I make just one comment before we move on?
Yeah.
As under a member comment, if I could.
Yeah, please.
Yeah, I just would like to, as it were, use this opportunity to ask my fellow board members to really, really take the time and step forward and have your input on the issue, on the task of defining what the director should be. It's very important that we do that.
Yeah.
And the other piece that is being worked on is a budget that originates from us, as opposed to, other kinds of departments. I don't mean the professional financial. I'm talking about a real public health, a real Board of Health perspective on what we consider to be a Board of Health budget.
Great.
So those are the two pieces that we need to have. I think the description is step one, and the other thing is the budget. And I've already captured a volunteer. And Dan, I would love to have you come in and say, no, it costs, this is what it really would.
I haven't looked at a health department budget in a while, but I can certainly look back at my resources from my previous life and see what I could.
Well, go into the present era though, because that's been such a long time ago.
Yeah. Multiply everything by 2. Yeah.
Okay. Thank you very much, Mr. Chairman.
Thank you. Is Jen Gold there?
Hey, can you guys hear me?
Yeah, sorry about that, Jen. We just
That's fine. No, apologies for stepping in too early. Just recapping what I said earlier, getting back to the question of the waiver for the high school at the 80% vaccination rate. So I heard Mr. Zeldin say something along the lines of rethinking the waiver because the criteria have been obliterated and starting from the beginning. And what I want to understand is why we would need to start from the beginning and rethink the waiver from scratch when the waiver had very specific criteria and conditions built into it around case counts, transmission rates, et cetera. I mean, that was the purpose of those conditions, was to set context for the waiver. So why, I'm asking Mr. Zeldin and anybody else that wants to comment, why we would want to start from scratch, which to me seems inefficient when we all sort of...
I think it's very inefficient. Yeah, and that's just Mike's opinion.
Mike, Mr. Zeldin, what would you say about that?
Well, Jen, can I call you Jen?
Yes, please.
Okay, wonderful. Okay. First of all, I have a much more, shall we say, not necessarily positive, but slightly different perspective on this. And I have a feeling that you have the notion that I think that we're going to go on forever, or at least for months and months and months and months, doing this kind of stuff of masking and taking masks off and on. We could very well be at the place where I'd like us to be, where we can say, we can establish a condition where everybody can take off their masks. Okay? And it's conceivable we could reach that if we stay in the game. I know you've heard this before, stay in the game a bit longer with whatever tools we have at our disposal. There are tools that are coming along that are not here yet, including in the works, different kinds of and improvements on our existing vaccines. And I'd just like to remind everyone, these vaccines are designed to reduce severity of disease and hospitalizations and deaths. They're not designed to clean out the virus. This is not China. We're not locking down a whole city because they have 2 cases. This is what's going on in China. All right? That's not what the US is about. Our economy is not built around, it's capitalist. So we got to keep moving here. So I'm looking forward to the time where the condition is different, where not only are 80% or whatever the number is vaccinated, but we've had something that goes beyond boosting. It could very well be another round of a different kind of vaccine, which all the companies are churning away at the moment. The other thing I'm looking for, very frankly, is I'm not trying to sell stock, but there is one of the pharmaceutical firms has repurposed a drug and dressed it up, and it's very effective in cutting the virus off at the feet. It's basically the Achilles heel of every virus. This one has to be designed specifically for the class of coronavirus that we're trying to deal with. And it's frankly, it could do Delta, Omicron, and the next 3 or 4 coming. So assuming the side effects are palatable and the regime is not, and the government or, the pay for this makes sense, we may be looking at a very different situation in the next several months. And I just want to get to the point where we can, as it were, take the masks off, deal with the reality we're going to be living with COVID. Maybe, Jen, that's the take-home message. At some level X, we're going to be living with COVID. And what that is, I can't tell you, but I'm hoping that we'll see the glimmers of it, if not in the next 3 or 4 weeks, hopefully by the end of February. I'm just saying hopefully, because I don't know, but I am hoping that another variant doesn't pop up that makes Omicron look like powder puffs. I don't know if that helps you, Jen. I don't know if that says, it's not a question of satisfying you. It's just, I don't think anyone on this board is interested in having anyone masked, including kids, including students, including young people. I don't like curtailing their social activities. I don't like curtailing their ability to find ways of getting into trouble, because I like to keep the parents on their toes. I mean, this is not healthy.
Right. I'm glad that we agree on that, Mike. And that's encouraging to hear you say that you do want the masks off at some point. So that's good. I wonder about the tying, similar to what Justin said earlier, tying the mask mandate in our town to the DESI mask mandate is interesting. I don't really understand the notion of tying those two together. But if you are going to tie our town mask mandate to the deadline that DESI has set, my question would be, why not go all the way and just mimic what DESI has done, which is to say that if a community or a school has an 80% vaccination rate, let the masks be optional. So, using DESI's guidelines of February 28th, masks optional at 80%. That would seem to me to make sense.
Okay, I don't know how to explain this any other way, but that 80% number, as you can clearly see from the number of cases and the number of hospitalizations, which, by the way, I need to add, I just checked, the Bella Rica folks stopped getting data on hospitalizations 3 months ago. So that they don't know what they're flying blind as well. So what I'm trying to say is, what I'm trying to get at is that I can't think of the school separately from the rest of the town. The school is heavily impacted by it. We're heavily impacted by what happens if the school is, shall we say, threatened at a greater level. Masking does help. It's not the best thing that helps is more people getting vaccinated. And it may take something else to get people in the schools vaccinated more fully so that we can stop the spread that you see, because that spread, when they leave the school, goes out into the community. That doesn't mean that it's not working the other way. I'm sure it is, that it's the community that's spreading into the schools as well. So
if I may add a little bit there. I voted yes to that motion. In my mind, I did not tie our response of having a mask mandate to what DESI is doing at all. Those are independent for me. Logistically, it felt very natural to pick our next revisit date to parallel DESI, simply so we wouldn't get into a situation as a board to say, if DESI agrees in February to get rid of all masks and we've put a mandate until April, it could potentially just create some awkwardness. We would probably have to move it up in the schedule anyways. So for me, I just voted to say that seems like the next reasonable revisit point. Now, if I got data next week that this all disappeared, I think we could come together and revisit it sooner. It just felt natural for me.
Okay, I mean, that's encouraging to hear. I think I would have liked to hear something along the lines of let's follow the data over the next few weeks. I don't think COVID's going to disappear in the next week or two, but I do think from what we've seen around the world, communities who've had Omicron earlier than we have, that cases are going to start going down. So I would like to hear some rationale around maybe case counts and severity and hospitalizations to rethink, to reconsider the end date of the town mask mandate rather than tying it to DESI.
I think we didn't have kind of a thorough discussion verbally, but I think we're probably all thinking similar things. For me, it's big about hospitalizations. I'm not really as concerned about having hospitalization data for Littleton residents right now. It's enough for me to know that if all of the hospitals that are in my area, in my community, where my community members would need to go, if they're full, that's still a problem for me that I have to face. So yeah, case counts, we've gone from a quality virus to a quantity virus in my book. There's a lot more of it, but man, the thing I worry about most is that hospitalization chart going up.
Yeah, and I'll leave you with one last thing. I know this came up with Katrina, and I encourage you all to look this up, but the Massachusetts Department of Health went on record, I think earlier this week, or maybe it was this weekend, that stating that, in fact, when people are admitted to the hospital for any reason, a car accident, a broken ankle, whatever, they're tested, of course, as a matter of course. And if they are tested positive for COVID, regardless of the reason they ended up there, they immediately are tagged as COVID, and that data goes in as a COVID hospitalization. Now, the DPH has admitted that was an early, from almost 2 years ago, they did that at the beginning to understand PPE and other necessities that the hospitals would need, but that's an outdated form of measurement and an outdated metric, and that they are going to start in the next week or so recording and reporting COVID hospitalizations as hospitalizations for COVID, not with COVID upon entry. That's huge, and that's really important. From everything that we're seeing, these cases are being overreported by about 50%. About 50% approximately of cases that are being reported as COVID hospitalizations are just coincidental COVID. So that's huge. I mean, that's a huge factor of, a differential. So I think that'll be really important to look at those numbers starting in the next couple of weeks.
The other thing I want to point out, I'm sorry, Jen, but the other thing I want to point out is it's very useful for the hospitals to have a handle on patients coming in with car accidents and, they test positive for COVID, because that basically tells them something about the, shall we say, the burden they're going to have to carry to protect their staff and other patients. So when we talk about cases, that they're exaggerating cases, I think the purpose of it and the way it was used was, it's just not PPE, it's also time and type of personnel. And a lot of folks who get worn out, very frankly, get worn out very quickly, and who have admission responsibility and maintenance responsibility and clinical management, because the clinical management has to take into account, I got a patient here who's got COVID.
Yeah, I get that. And I respect that. I think it's just important to understand that, an over-reporting of up to 50% of cases, being because of COVID, hyperbolizes and really over-exaggerates the severity of COVID resulting in hospitalizations. So I get your point. I'm not saying they should stop recording that information, but the reporting out of it really needs to be clear around why people are being hospitalized. It's not for COVID. The numbers are going to be dropped down by about half. So I just think that's important. Thank you, guys.
Thanks. Anyone else?
Yes, Justin Keene.
Good evening. Hi, can you hear me?
Yes. Hi, Justin.
Great. Hi. First, I think the chair, you've done a great job this evening. It's been a tough discussion. You did a great job navigating and moving it along. Otherwise, I'm very disappointed by a lot of what I heard tonight and almost appalled at some of the things that went on. We're in the middle of a pandemic, and we're making jokes about pretty women standing 4 feet away. and you guys didn't say anything. I have sons, not daughters. If I had a daughter listening to this Board of Health meeting, I would have.
I missed that comment. I don't know.
I didn't hear that.
Yeah.
Okay. Well, that's there. You interrupted multiple times. You interrupted Mr. McCarthy while he was speaking, and then sought to cut him off with the 2-minute rule. You laughed at him when he had the temerity to suggest that there might be data. You guys are not sacrosanct. You are public servants. We are all tired of this pandemic. We all want this to go away, but the tone and the way you were treated some of the people tonight was appalling. You are not above reproach. We are deserving as a public of being treated with respect, not laughter, not condescension. You are not the sole possessors of knowledge and wisdom about
Yeah, of
COVID.
course. Yeah, I don't think anybody on this board believes that.
Well, I think that I'm getting the impression that comes across sometimes, particularly in the treatment we saw tonight. And it's disappointing. And I would encourage you to go back and listen to one of your members make a joke about pretty girls only have to stand 4 feet away. And I hope none of you are going to go, that.
Yeah, I honestly do not even know if that was said.
Well, I heard it.
Yeah.
Most of the people, a lot of other people heard it too. So.
Well, I will certainly.
Thank you for your time.
And there will certainly be ramifications if that was actually said during this meeting. So thanks, Justin. Is there anyone else, Janet?
TJ? Sorry, I don't know why I'm having a little trouble here. No, I don't see him anymore. Looks like that's it right now.
All right, so another name flash up. Is that just anybody?
Yeah,
in the audience?
I'm having some trouble with my Wi-Fi tonight. No, I don't have any other hands in the public. That's it for tonight.
All right. Do we have a motion to adjourn?
I'll make a motion to adjourn.
Second.
All right. Roll call vote. Dan Kane.
Dan Kane, yes.
Matt Wason.
Matt Wason, yes.
Mike Zeldin.
Mike Zeldin, yes.
And Kevin Baker votes yes. Thank you, guys. Gino
Thank you.
Felsen.